thank you very much for the invitation and the very kind hospitality. I'm very happy to come back to Greece. I've been here several times and I'm always happy to be here. So I'm coming from the southern shore of the Mediterranean, and I want to transmit a picture from a country where both are prevalent. We have a lot of hepatitis C, we have the highest prevalence in the world, we have a lot of thalassemia. So what is happening with this combination? First, just look at this lovely picture, and then at the end I will tell you what it is. So, to catch up, hepatic fibrogenesis, this is a wound healing process, irrespective of the main injury to the liver. The end and the ultimate result is the stimulation of certain mechanisms which will lead to hepatic fibrosis and hepatic cirrhosis and then end-stage disease. Previously, some preferred to say that this is the iron or it is the hepatitis C, but I think it is both. So, as hepatitis C starts with acute hepatitis, and by the way, you see a lot of acute hepatitis C, and then the fate is either the resolution or the chronic evolution, which is more common, and then it is either stable or progressive until the ultimate cirrhosis. So during this journey from the acute hepatitis, of course, many changes occur until we go to the end-stage liver disease, HCC, and transparent or death. So it starts with the capillarization of the sinusoids, which will change, which will change this normal liver with the activation of the stellate cells, with the activation of many mediators, cytokines, and then activation of stellate cells and the extracellular matrix with the excrete deposition of collagen. So, hepatic progression rates are important criteria. It's not important only to say that there is fibrosis or to diagnose fibrosis, but it is this important point which is very difficult to assume. It is how fast the fibrosis is progressing. And according to the fibrosis progression rates, we have either the slow progressors, the medium progressors, or the rapid progressors. Why this is different? Because to measure the fibrosis progression rate, we need more than liver biopsy. And the patient refuses one liver biopsy. So what if it is 2 or 3 liver biopsies in order to estimate the fibrosis progression rate? One important aspect is that the fibrosis progression is not linear in cases of hepatitis C. So we cannot even have a correct model, although there are several models, and the French are very good in putting the models for fibrosis, and it will not fit all the forms of disease. So, in many cases of accelerated fibrosis, it is always this second hit. It is hepatitis C, and then there is another mediator or another factor which will cause the acceleration of fibrosis. This can be steatosis, this can be alcohol, toxins, iron, co-infections, and we have a good example with HIV or schistosomiasis with different immunosuppression forms. Also, we have genetic factors. So these many factors will contribute to the second hit, and after this, the injury with hepatitis C and this second hit, this will accelerate the fibrosis either to the full established form of cirrhosis or to hepatocellular carcinoma. And so this is what we see in case of thalassemia. It is a second hit, and sometimes in certain situations and in certain high prevalent countries, we have a second hit and a third hit and the fourth hit and the end result may be a very fast progression which can occur in very few years, which is not typical to the long 20 or 30 years. So fibrosis is very important, and what is really more important as well is the fibrosis progression assessment, because this is a true method for the assessment of the severity of the disease and can predict the outcome of this infection. So, of course, it's very relevant to assess the fibrosis by diagnosis, and we can use this in prognosis and will help us to have our treatment decision. And most of these studies are cross-sectional, and they will say, okay, for example, FibroScan is parallel to the liver biopsy at sometimes. It is cross-sectional, and the majority of these studies are belong to this group and criteria. But here the fibrosis progression studies, and these are longitudinal studies, they took a very long time, and it is very difficult. Because in order to assess truly and effectively the progression and the natural history, you do not need to treat. And of course now in this era, it is not ethical to leave the patient without treatment. So there are few truly natural history studies. But there are some longitudinal studies for fibrosis progression, and we will come to this in a minute. And this is very important to monitor the treatment effects, to see the effect of the drugs on the histology of the liver. So, in the previous presentations, okay, we know that patients with hepatitis C and iron overload, they have a more severe form of fibrosis, and they have more severe progression or accelerated progression of their fibrosis. And it is similar with HIV. In Egypt, for example, it is similar with hepatitis C and B, or hepatitis C and schistosomiasis. And of course, this is classic, and we have seen this for 5 or 6 times today. I will not go through it because it is becoming a classic presentation. So this is one of our recent work, which is in press now, and here we will compare the fibrosis progression rates. And this is a unique cohort of patients who have one or more liver biopsies. And so here we depend on the direct fibrosis progression rate, in which we have 2 biopsies or 3 biopsies, and we take the fibrosis stage in the last biopsy and subtract it from the initial biopsy and divide it by the number of years. Here we compare the patients with HCV monoinfection with no thalassemia, and patients with thalassemia without HCV infection, and thalassemics with hepatitis C infection, and it is clear that those have the highest rate of fibrosis progression, and these are fibrosis progression units, and depending on the difference between the 2 biopsies. So we come back here. This shows us that fibrosis progression is increased in thalassemic patients, and it is significantly increased compared to the hepatitis monoinfection without thalassemia. But hepatitis C even increases their fibrosis progression compared to those who are not co-infected. Then we move to an important point, which is the main focus of this, which is how to diagnose hepatic fibrosis. Of course, it has been for many years an invasive technique using liver biopsy, and of course our patients are very, very angry with us when we tell them that we have to do a liver biopsy before treatment or for anything, and of course we will be very much discouraged if we tell them, okay, we want to repeat the liver biopsy. And now it is an era to move to the non-invasive techniques, which are now gaining ground. They are becoming more successful, but our question, which we will try to answer, will they this time replace completely the liver biopsy or not? This includes the serum biomarkers of fibrosis, the elastography studies, and the imaging studies. So, to measure the hepatic fibrosis progression using either the liver biopsy or, as I will show now, we can also measure it using the non-invasive techniques. We have two methods. The first is the direct method. And here we have to do liver biopsies, serial liver biopsies, and the more the spacing between the liver biopsies, the much better is the score we get, because here we have slow progression. And this is the different biopsies. And the indirect form, this is a single biopsy. And we use an estimated date of the hepatitis C infection. And this is a difficult one, because many of patients do not know exactly how they contracted the HCV infection. So we get it approximately from an incident, and we take this interval, and then we find the biopsy, and we divide by the number of years. But of course, studies depending on the direct measurement of the hepatic fibrosis are more accurate in this respect. So liver biopsy, this is the classical method, and it has been for a long time and the gold standard, because it is a good method for estimating the degree of inflammation, estimating the degree of fibrosis, and importantly in thalassemia, we can also assess the liver iron concentration. But it is invasive, of course. All the patients do not like it. There are adverse events. It is expensive, and this depends on the situation. And in some countries, for example, in the U.S., it's very expensive because patients are admitted to hospital and it takes a time. But in some countries, it is, for example, in Egypt, it is much less expensive to do a liver biopsy than do biomarkers. And of course, there is inter-observer differences and difficulties in interpretation. And of course, there are plenty of histological scoring systems in order to interpret this. But the problem with this is that we really need spacing. We need we need many patients to be enrolled in the study. We need to repeat the biopsy for at least 8 years or 10 years or more. And sometimes it is the follow-up biopsy may be too insensitive to detect minor changes in fibrosis. And so this is a big panel of imaging techniques to start with the transient elastography and then more recent techniques. That is the ultrasound-based elastography, the magnetic resonance elastography, the acoustic radiation force impulse images, or the RFI, and the cross-sectional imaging, which has been there for many years. For the serum biomarkers, of course, it is very nice. It is just a sample of blood, and it is analyzed. It will give us the result, and it is very convenient for the patients. And the biomarkers of fibrosis are divided into two important categories, the direct and the indirect. The direct means that they will detect some mediators which are actively involved in the process of fibrosis in the liver, such as markers, single markers, as the P3NP or the YAP40, or markers of matrix degradation or matrix deposition. So these directs are really related to the process of fibrosis. And the indirect, and these are mostly indices, where they use simple tests and they collect them and combine them in order to have a special index or score, and we have a lot of them, and again, the French are very good in this. They are very good in doing these scores. So, what is an ideal marker for hepatic fibrosis? It is not invasive. We just take a sample from the serum or the blood. It will be cheap and easy, and preferably it is done at the point of care. We do not need to collect samples and take them to a central lab. For example, it is very easy at the point of care, and it should be dynamic. This means that it can grab the changes in fibrosis or reversibility after treatment if possible, and it truly reflects the degree of fibrosis as shown in a liver biopsy. So many of these scores are now available, and the accuracy will increase or decrease according to the different items which are involved in these scores. And many studies compare these scores with another technique or with the liver biopsy. And for example, this is our work where we compared two of the direct markers, the YKL40 and the TGF-beta, and especially TGF-beta is very actively involved in the process of fibrosis with the elasticity measured FibroScan, and we find that it's okay. We can work with a single or more than one technique in order to detect the progression rate, especially in the thalassemia with chronic HCV. So here, the current status of the serum markers, a single serum marker or a single score may be effective in about 50% of cases. But until now, it takes the diagnosis of the extremes, the early stages or the late stages. But it's still insensitive to grab the progression, how the progression is occurring, and also it does not detect the regression if there is a regression after treatment. So the other technique which is also gaining grounds now is the FibroScan. FibroScan has a good sensitivity. It is a good technique because here it is non-invasive. You do not need to take a biopsy, and you measure simply the elasticity, and it gives us a good exposure, much more than the exposure we take with a single liver biopsy. And what is good, it gives us the results immediately. We do not need to wait for a pathologist to read the biopsy, or we do not need for the results of the lab to give us the evidence of the biomarkers. So this is a study which looked at the FibroScan values in thalassemics with HCV positivity and HCV negativity, and they compared both, and it showed that in the early stages, which are less than the standard 7.7 kPa, we will find, okay, more patients HCV negative are in this category. But as we go forward, we will find that HCV positive patients are more and more with the more levels of transient elastography. This is also our work, and here we compare patients who are thalassemics, HCV positive and HCV negative, and we have in this FibroScan done at baseline and FibroScan 6 years later, and as it is shown, there is significant increase in the transient elastography levels, and this correlated very well with the liver biopsy. The second technique is an easy technique. It is ultrasound-based elastography. It is based on the ultrasound procedure, but here it is also it measures the elastography and the tissue stiffness. What is nice in it? It is not expensive. It is less expensive than the FibroScan, but it has the problem that it is not widely spread in certain places. This is a new technique that with the acoustic radiation force impulse imaging, and this uses the short duration, high intensity acoustic impulses to produce mechanical excitation in the tissue, and this results in the localized tissue displacement, which is then measured. the use of the ARFI for imaging is very good in F2 and F4. So we are not adding a lot. We are taking the extremes, but at least we can repeat it. It can be repeated more than one time, and it is adequate and it's not invasive, but it cannot be done very well in obese patients. So the last one is the magnetic resonance elastography, and this is one of the very popular non-invasive techniques, especially in thalassemia, because it can detect any form of fibrosis. Any form of fibrosis, starting from the low levels of fibrosis, then the gradual levels F2, F3, and F4, and also it can assess the levels of iron. Of course, it is more expensive than the previous techniques, but at least it is very well used when we follow up with the epidemic of the hepatocellular carcinoma. We are seeing increasingly in patients with HCV and thalassemia, or HBV and thalassemia, which is a big problem in my country. So, to improve the performance of these non-invasive hepatic fibrosis markers, because today we do not have this dream marker. We do not have this marker which satisfies all of these criteria, being non-invasive, reliable, valid, all this. So it is the combination of more than one marker. A combination of two serum biomarkers, or a combination of one something like elastography with a biomarker, or some of the imaging techniques, and this increases the performance to levels that are very close to levels of the liver biopsy. So, to conclude, hepatic fibrosis is more pronounced in thalassemia patients with hepatitis C, and for what we see, both are important, the liver and the liver iron and the HCV, and the acceleration is not the severity, but also the acceleration. If we say that in normal hepatitis C monoinfection, the fibrosis progression rate is about 0.1, here it is 0.4, and the highest is 0.8 in HIV and schistosomiasis. So it is in the middle, but it is accelerated. So more markers are needed to be evaluated. The combination of the markers is very important. The modeling for the prediction of the level of fibrosis is important, and this is important to prioritize and ration therapy, because now we are dealing with very expensive therapies. And so we have to prioritize who will receive first and who will be delayed a little bit. Thank you, and I will just tell you, this is the this is liver in hieroglyphic, and it's called MIST. This is the first case of advanced liver fibrosis with ascites, with edema, with gynecomastia. And this very nice ancient Egyptian statue is in the Museum of Berlin. And also, this is another documented one. As you see here, you can see the ascites, you can see umbilical hernia, and here also. So it has been there. It was not due to HCV. It was not due to HPV, but it was schistosomiasis, which also leads to this fibrosis. So fibrosis was known in very ancient time, and with the full-blown picture and the late stages. Thank you very much.